Okay, so let's go on to headaches. And there's a couple of very common headaches that we're going to mention here. And the first one is a tension headache. And this is an extremely common headache, and definitely it'd be the most common headache that we can suffer from. And usually it's due to tight contracting muscles of the scalp. And classically, it's at the front of the head and the back of the head. So it feels like a band is going around your head, a tightening band. And often it's from either poor posture, ongoing anxiety where the muscles are tightening a lot, teeth grinding at night. A lot of people don't know that, but they grind their teeth, and that's hard on the muscles of the scalp, and you can be left with tension headaches. It's a bilateral headache, so it's on both sides, at the front and often at the back as a tight band. You don't usually have vomiting, photophobia, which is your eyes really hurt to bright light. Phonophobia is your ears really hurt to loud sounds. That's not associated with a tension headache. That will be more associated with a migraine headache that we'll talk about. So what's the treatment for a typical tension headache? Well, I mean, a good idea is if there are things happening in life that are impacting you and causing tension headaches, to address those issues. But medication-wise, acetaminophen, aspirin compounds, NSAIDs, and trying to avoid caffeine. Okay, caffeine can lead. I'm sure many of you drink coffee, or some of you drink coffee. You know, if you miss a day of coffee, what happens? You often get a rebound headache from missing the caffeine for that day. So telling people to avoid caffeine because that can aggravate a tension headache. Now let's just look quickly at the bottom here, the different headache types. A sinus headache, well, usually it's in the setting of someone with a cold and one of the sinuses is plugged. It can't drain into the nose where they typically drain. And they're often frontal headaches. So you can see at the top there, those are frontal sinus headaches. Or below the eyes, because there's a sinus there called the maxillary sinus. And so you can have pain, facial pain in there because the sinus is under pressure or it has an infection in it. Tension headache, we just spoke about, at the front and the back, tight, band-like. A migraine headache is usually a pulsating, throbbing headache on one side of the head. This is often associated with a whole bunch of other symptoms that we'll go over on another slide. And the next one we'll talk about a bit more as well. It's a type of migraine headache, we think, called a cluster headache. And that is really localized around one of your eyes. And it really is described like a knife going into your eye. It's a very painful headache. And often it's associated with tearing of the eye and also clear nasal discharge on the same side of the cluster headache. So we'll get into that a bit later. Okay, so let's go on to migraine headaches. We mentioned tension headaches, and typically your acetaminophen and your NSAIDs are what you would use for your tension headache. A migraine headache, we don't know the exact cause, but we think it's from vasoconstriction and vasodilation of blood vessels within the brain that gives these pulsating headaches on one side of the head. Okay, there's often triggers to a migraine headache. It can be acute or chronic stress. Women often describe a link to hormone shifts in their body during periods. Excessive exercise, that wouldn't be a common one. Lack of sleep definitely can aggravate migraine headaches or bring on more migraine headaches. Hunger or certain smells or foods can trigger migraine headaches. For example, some people are triggered by wine. Red wine and the contents of red wine can trigger a migraine headache. They're definitely more common in women than men. And so what are the symptoms? So people usually come in, they're usually wearing sunglasses when they come in, and they look miserable, and they describe a severe unilateral throbbing painful headache, and sounds bother them, the light bothers them, they're often vomiting, they want to be put in a dark room with very little noise, and they just want to lie there and try to get rid of this headache. Often people know, often with people with recurrent migraine headaches get this aura. So it's often it's something that happens before the headache comes. So it's some kind of a disturbance, a sensory disturbance that happens before the headache hits. And most auras are visual. So they might get see lights in their vision, or they might have a part of their vision that's broken up a bit. It doesn't look normal. Those are called scotomas, visual scotomas. They might notice that their taste is different. They might have tingling in the part of their body. And as a severe presentation of an aura, half of their body might be temporarily paralyzed. And when they first come in with this, of course, we think this is a stroke until we do an urgent workup with CAT scans, and we realize, nah, I don't think this is a stroke. This is a really severe presentation of a migraine headache. So that's what an aura is. It's something that precedes the headache, the migraine headache. So how do we treat this? There's a whole bunch there's many treatment options for this that we have tried. And we'll often give them injectable medications because they're vomiting so much, so they need something for nausea and vomiting. They also need, we use anti-inflammatories, NSAIDs, and we use a group of medications called the triptans. And these medications came out about 15 years ago, and they try to control the migraine headache at its source, where we think the vasoconstriction and the vasodilation of the arteries are causing the problem. So the other treatment that we used to use, which you might see on an ATI or NCLEX, is a drug called ergotamine, ergots, ERGOTS. And what they were powerful vasoconstrictors that we used to give as an injection or as IV. And they would vasoconstrict the blood vessels in the brain to try and control the migraine headache. We don't use those very much anymore. You can imagine giving someone injectable vasoconstrictors. It's not great for someone with angina or coronary artery disease. So we've really gone away from that group of medication called ergots or ergotamine. So cluster headache, we think, is a type of migraine variant. And what this is clusters of really bad headaches that come very, very close together. So it's these repetitive, intense, stabbing pain, usually around one of the eyes. And it's really quite miserable. Most people describe it as a knife going into their eye. And often they come in holding their eye. So you think they might have acute glaucoma, something, they may have something else to do with the eye. And often they'll get 15, 20, or 30 of these in a week. So that's why they're called clustering. And that eye also has tearing, so they're crying on that one side. And as you know, the tears go to a drainage system, the tear duct, and then drips into your nose. So often they have a nasal dripping on that side as well. Okay, so this is a really severe headache. It's more common in males, which is kind of strange because migraine headaches as a group much more common in females. Cluster headaches more common in males and smokers. And what do we do for this group of people? Well, it often seems a bit strange when we're putting a high flow oxygen mask on them, and we will turn up the flow of the oxygen to a very high level, and we'll let them sit there with high flow oxygen on, and that will sometimes improve the cluster headache. The other group that we use is the same group that we used or that we use in migraine headaches, and those are the triptan groups. Maybe people have heard of sumatriptan, which is Imitrex. There's 5 or 6 in the triptan group now, and they're commonly used for migraine headaches, and we'll try them in cluster headaches. I think I'd remember the high flow oxygen for cluster headaches, because that's a bit of an odd treatment, and it's one that sticks out. So not a bad one to remember. Okay, so we're just touching upon different topics in neurology. Let's go to the neurodegenerative diseases. So neuro, nerves, degenerative, they're breaking down. And depending on where the nerves are breaking down is going to give you the disease complex that we'll be talking about. So Parkinson's disease is a neurodegenerative disease. It's much, much more common in older people. It is possible to get it in your 40s or 50s, like Michael J. Fox, but it's very uncommon in those age groups. Most of them are in the 70s and 80s when they develop Parkinson's disease. And the underlying problem with Parkinson's disease is loss of dopamine producing nerve cells in a part of your brain called the substantia nigra. Okay, and this part of the brain is very involved in posture, walking, and muscle tone. So you'll see with the symptoms that'll make more sense. That when this part of the brain is gradually losing its dopamine producing cells, that these symptoms will occur. So a lot of them are movement related symptoms because that's what this part of the brain helped with. So they often have a resting tremor. So if you would look at their thumbs while they're sitting, they have this resting tremor of their hands and their thumb that's just moving rhythmically back and forth. They're bradykinesic. So everything they do is slow. They walk slowly, they talk slowly, they grab their cutlery to eat slowly. Everything is in slow motion. They often have a stooped posture, meaning they're bent over forward. If you were to check their, to ask them if you could open and close their elbow just to feel how smooth their muscles are, they'd be very stiff for them to open, to extend their arm and then flex their arm. Very stiff muscles. They have this really classic shuffling gait where they're not really lifting their legs anymore. They're just kind of shuffling forward. They have low volume speech, hypophonia, really low talking, low volume, gait instability. So they're very easily knocked off balance. So so they're stooped over, they're shaking, they're unstable when they walk, and that's one of the problems, that these people can fall over very easily. So if someone with Parkinson's is in front of you, it might just take a tiny little push, really small little push, and that would really knock them off balance. Parkinson's patients often develop depression, extremely common. And later in the disease, they often become incontinent. And even later in disease, they develop Parkinson's dementia, where their memory, their short-term memory, is now severely impacted. Unfortunately, there's really no cure for Parkinson's yet. A number of surgeries have been tried to try and replace those dopamine cells in the substantia nigra. Not great results have occurred. There's many drug treatments to try and replace the dopamine that is being lost in the substantia nigra. So many people are on medications for Parkinson's disease because of the muscle issues, stiff muscles, really weak, poor gait, stooped posture. We send them to physiotherapy. They require a lot of nursing input. They're at risk of falls. They're incontinent. They have difficulty speaking. They have low voice. Occupational therapy to put safety rails in their house. Taking the carpeting out of the house, because that shuffling gait gets caught on carpets and then down they go. So there's a lot of things you need to change in someone's house that has Parkinson's disease to try and avoid falls. And we'll come back to Parkinson's disease and go over those symptoms a bit more. The next one is amyotrophic lateral sclerosis, ALS. A famous, I think he was a baseball player, Lou Gehrig. He developed this disease, unfortunately. And it's caused by loss of nerves to the skeletal muscles. So your brain is intact. You're able to think and compute things still, but you can see you're gradually watching your skeletal muscles waste away and not able to. You're losing your ability to move. So it can be quite rapid, actually. It doesn't have to be over the span of many years. And your muscles are wasting away. They're becoming very weak. So you develop difficulty initially walking. You can develop problems breathing. So obviously, if you develop problems breathing, you're at risk for pneumonias because you can't bring up the sputum. You can have difficulty swallowing your food because that involves voluntary muscles. And then that progresses to really inability to walk. You end up in a wheelchair, and it's progressive paralysis until you're completely paralyzed. And during all this, you're fully aware. Your brain, you're not demented. You're fully aware of what's happening. So it's it's a really unpleasant disease because you can see your physical body becoming paralyzed. And there's no cure for this either. So it's really a motor neuron disease, right? So the muscles, the nerves to the muscles have stopped functioning due to this disease, and the sensory, the input can still come to the brain, and the thinking and how you compute things and think about things is fully intact. Okay, so back to Parkinson's disease. This is a very common disease, so it's important to know a bit about it. And let's just go through the symptoms again. So they often have this, what we call a resting tremor, where when they're sitting there and they're trying to drink a cup of coffee or hold something, their whole hand is tremoring. Their thumb is going up and down. So we call it a resting tremor. Slow movement. It's really like watching a slow motion movie. It's painful. That's called bradykinesia. So brady is slow, kinesia is movement. Slow movement. Rigid muscles. So if you were to hold their arm and flex their flex their elbow and open their elbow, extend it, you'd notice that it's very rigid. It's not a smooth movement like yours. Impaired posture and balance. So they're often stooped over, their head is stooped down, and their balance is extremely poor. You could just touch them with your finger, and that might be enough to knock them over or to put them off balance. Speech changes. Well, that's the low speech. When they're writing, they write in tiny little words now. It's called micrographia. So whereas before they used to have full normal handwriting, they now write with little tiny words that are difficult to see. If you're walking around Salt Lake City, you're bound to see someone with Parkinson's disease. And you'll notice them because they're walking extremely slowly and they're typically bent forward. And that's typically how you'll notice someone with Parkinson's disease. Or you'll see them sitting somewhere and you'll see that their thumbs have a tremor, their hands have a tremor. And they're extremely slow with their meal or with drinking their coffee. Very slow movements. So let's go to the next neurodegenerative disorder, and that would be multiple sclerosis. And we're not actually completely sure of what causes multiple sclerosis. We think it might be an autoimmune disease. There's been theories that it might be a viral infection. We think it might be linked to vitamin D deficiency in certain countries where you're wearing you're wearing cold weather clothes all the time, such as where I am in Canada. So there's been links to vitamin D deficiency. There's been an assortment of theories, and this is a destruction of. I think that sentence is supposed to say central nervous system and peripheral nerves. I'm going to correct that a bit. I apologize for that mistake. It's typically a destruction of the myelin sheath, the cup that surrounds the nerves in the central nervous system. So now that would include the brain and the spinal cord. Okay, so this results in an inability to transmit signals properly. And multiple sclerosis can impact anywhere in the brain or the spinal cord. So depending on where it impacts is what the symptoms the patient will come in with. Okay, very common symptoms are, well, fatigue is just a very generalized. They come in with severe fatigue, and we do blood work and tests, and we can't find anything at the beginning. A very common presentation is a younger person that comes in with visual problems. They come in and they say they can't see well anymore, or they're seeing double vision. And that's from inflammation of the optic nerve called optic neuritis. So that's a common presentation of multiple sclerosis. A young person that comes in with loss of their normal vision. Another presentation is where they come in with incontinence. So a young person comes in and says, I'm incontinent, I'm losing my urine and I don't know why. That can be multiple sclerosis. They can come in with an assortment of things because the damage, the demyelination can be anywhere in the brain. So they can have right leg weakness if it happens to hit that part of the brain. They can have cognitive, so loss of their thinking abilities, depending on where it hits in the brain. They can have, I think the main ones I would think of as loss of vision, double vision, urinary incontinence are probably the most common ways people can present with multiple sclerosis. And it's usually between the ages of 20 and 50 is when people present with this symptom. And it's a long-term disease. You have it. And you can have flare-ups of it where suddenly you have significantly more symptoms. So for example, say you have multiple sclerosis, but it's stabilized a bit. Your vision's a bit better. You can have these flare-ups where your vision is significantly reduced again. The fatigue is much worse. Your right leg isn't working anymore. So it's a very chronic disease that has a stepwise decline, and some of them can be an extremely quick decline, and other ones are very gradual over many years. There are an assortment of medications that we try, including interferons. There's no cure for this disease. We often refer patients to physiotherapy to try and maintain any motor disabilities or walking difficulties. We try and maintain that as much as possible. People often have to progress to walkers and wheelchairs as the disease progresses. So there's no one way of describing multiple sclerosis because the damage to the myelin sheath can be in any nerve anywhere. So it really depends on where it hits. Huntington's disease, this is an autosomal dominant disease, and it's not a pleasant disease at all. You develop typically in your 30s and 40s is when you develop the symptoms. So you can imagine many people have already started families, and now they've acquired or they've developed the symptoms of Huntington's disease, where you have involuntary movements of your arms and legs and face, and you just can't control them. So obviously you're losing the ability to move, to eat, because you can't control the muscle movements of your arms, legs, and face. And it's really quite dramatic when you see it. Their arms and legs are flailing all over the place. It's sad to see. And they also have a loss of cognition and memory. So they're developing dementia. They often have depressive symptoms, anxiety symptoms, emotional lability. So you can imagine all of these things happening in your 30s and 40s is really a devastating disease. And there's no cure for this. A lot of people want genetic testing if they know one of their parents had Huntington's disease. And because it's autosomal dominant, people will decide about family planning if they have Huntington's disease. So with genetic counseling and genetic testing, you can find out if you want to whether you've acquired the gene for Huntington's, and then you can make planning because you can make plans for the coming years because it's very likely you're going to acquire the disease. So many people don't want to have families, don't want to have children if they know that they have the dominant gene and they're going to develop the disease. So here is a slide on multiple sclerosis, and you can see the assortment of symptoms that people get because those demyelinating nerves that are affected by multiple sclerosis can be anywhere. There's some very common ones though. So for sure the eyes, a 20 or 25-year-old woman comes in complaining of blurry vision in both eyes, we definitely think of optic neuritis caused by multiple sclerosis. Or a 25-year-old woman that comes in saying that she's incontinent. Okay, that's concerning for multiple sclerosis. But you can see that there's an assortment of symptoms here. And any of them could be multiple sclerosis. We probably won't get to the answer until we do an MRI of the brain if we suspect multiple sclerosis. There's some really common ones though. Profound fatigue is very common in multiple sclerosis. I mentioned the eyes. You can have a focal weakness of maybe one of your legs or one of your arms because there's demyelination of the nerves that's controlling the arm or the leg. As mentioned before, they can first present with incontinence at their bladder. They're unable to hold their urine. So I wouldn't memorize all these. It can cause anything. So don't think memorizing all these words is beneficial. I would just know in general that multiple sclerosis, if I was to give you the most common, it would be profound fatigue, presenting with blurry vision or urinary incontinence.